Every year, hospitals around the world face a critical challenge. Patients returning shortly after being discharged. These are called hospital readmissions, and they are not only costly, but may also signal gaps in patient care. In this study, we explore a real-world dataset, the Diabetes 130 US Hospital dataset, which contains over 100,000 patient records collected from 130 hospitals over a 10-year period. Our goal is to understand a key question. What factors can predict whether a diabetic patient will be readmitted to the hospital within 30 days? To answer this, we performed exploratory data analysis, examined class imbalance, tested classification models, and evaluated ethical implications of using sensitive patient data. Ultimately, our aim is not just prediction, but responsible prediction in a healthcare setting.
The dataset we used comes from the UCI Machine Learning Repository in Kaggle. It contains 101,766 patient encounters and around 50 features. This feature include patient demographics such as gender, age, and race, clinical information like diagnosis, lab results, and medications, hospitalization details such as admission type and discharge disposition, and most importantly, the readmission label: no, less than 30 days, and more than 30 days. However, one important issue appears immediately in the data: the class imbalance. Most patients were not readmitted, while only a small portion were readmitted within 30 days. This imbalance plays a major role in how machine learning models learn from the data.
From our exploratory analysis, two patient attributes stood out as the strongest predictors of 30-day readmissions. First is the number of diagnoses. Patients with more diagnoses, often around 9 or more, were more likely to be readmitted. This reflects higher medical complexity and the presence of multiple chronic conditions. Second is the number of medications. Patients taking more medications also showed higher readmission rates. This suggests more complex treatment plans, increased risk of drug interactions, and greater overall disease severity. Together, these two factors point to a clear pattern. Patients with higher clinical complexity are more likely to return to the hospital. However, before building any predictive model, we must address a major issue: class imbalance. Most patients in the dataset were labeled no readmission, while only a small number were readmitted within 30 days. This creates a serious modeling problem, such as the model may simply predict no most of the time, accuracy becomes misleading, and high-risk patients may be missed entirely. We should also consider techniques such as smooth oversampling, class weighting, and threshold tuning. These help the model better detect minority class patients.
We tested multiple classification models including logistic regression, decision trees, random forest, and gradient boosting methods like XGBoost. Among these, random forest and XGBoost performed the best. Random forest was chosen for its balance between performance and interpretability, while XGBoost showed strong predictive power for structured medical data. These models perform better because they capture nonlinear relationships, handle feature interactions like diagnosis and medications, and are more robust to noisy clinical data. To evaluate performance, we used recall, most important for detecting readmissions, precision, F1 score, ROC-AUC, and the confusion matrix. These metrics ensure we measure how well the model identifies high-risk patients, not just overall accuracy.
While our model shows strong predictive ability, there are important limitations and ethical concerns. One major issue is the use of demographic variables like race, age, gender, and weight. Although these features may improve accuracy, they raise serious concerns. Race, for example, is not a biological factor, it is a social construct. So using it in prediction models risk encoding historical inequalities rather than true medical risk. Age and gender are clinically relevant. Weight may also reflect social and environmental conditions, not just health status. The danger is that the model may unintentionally reinforce healthcare disparities, leading to unequal treatment outcomes. Because of this, demographic features should be used carefully, auditing than direct predictions. So, based on our findings, we recommend the following. First, clinical systems should prioritize high complexity patients, especially those with many diagnoses and medications, as they are at higher risk of readmission. Second, any predictive model used in healthcare should be trained using imbalance-aware techniques, be evaluated using recall and F1 score, not just accuracy, and be regularly tested for fairness across demographic groups. So third, demographic features should be used cautiously, ensuring they do not introduce bias into clinical decision making. Finally, models should always support, not replace, clinical judgment.
In conclusion, predicting hospital readmission is not just a technical challenge, it is a clinical and ethical one. We found that patient complexity, especially the number of diagnoses and medications, are the strongest predictors of readmission. However, class imbalance and ethical concerns remind us that machine learning in healthcare must be used responsibly. Because, in the end, the goal is not only to build accurate models, but to build fair and meaningful ones that improve patient care for everyone.